Welcome to this week's PowerPoint. We have two categories that we are looking at this week. One is gender dysphoria, and then the other category is going to be looking at disruption, impulse control, and conduct disorders. So the first one we're going to look at today is gender dysphoria, and that is basically one chapter all on its own in the DSM. And in gender dysphoria, we have a lot of things going on. If you would like to take a look at this in your DSM-5-TR, that starts on page 512 with a little bit of description starting on page 511. So one thing that might be useful is just a couple of definitions that are presented at the beginning of this chapter in the DSM. So one of the challenges in the English language is that sex refers to both male or female or other identities, as well as sexuality. So we have a little bit of an issue when we're trying to distinguish between sex and gender. Sex typically is going to be looking at the biological indicators of male or female based on things such as sex chromosomes, gonads, sex hormones, etc. Gender is our term that we are going to use to denote public, sociocultural, and lived role as a boy or girl, male, man or woman, or some other gender. Gender assignment is going to refer to the assignment at birth, typically. It might be referred to as natal gender. And then gender identity is the category of social identity that refers to an individual's identification as male, female, or some other category, such as gender fluid or gender neutral. When we talk about gender dysphoria, we're really looking at a general term that could be used as a diagnosis, but the general descriptive term is referring to the distress that might accompany the incongruence between one's experienced or expressed gender and a person's assigned gender. So when we're looking at the actual diagnosis, the first thing that might be important to mention is that this is another one of those changes between the DSM-4 and the DSM-5. In the DSM-4, we did not have gender dysphoria. We had the term on the diagnosis of gender identity disorder, and that was focusing more on the identity part. Here we are focusing more on the dysphoria as the clinical problem. So the problem is not the identity, the problem is the dysphoria. So when you're looking at this, we are first of all going to be looking at different criteria for children versus adolescents and adults. And the key piece here, again, is that marked incongruence between the gender that the individual has been assigned and their experienced or expressed gender. That is the core of that diagnosis. In adults, we might see, in addition to the dysphoria, a desire to be rid of primary and or secondary sex characteristics, or that they might want to acquire the sex characteristics of the other sex. Many people will adopt behavior, clothing, and mannerisms before they do anything else. And then you might see some of the movement in between looking at some form of medical treatment to shift some of those sex characteristics. So first of all, we might have people at kind of that initial level who might choose to dress and behave more as the other sex. We might see things such as women binding their chests so that their breasts are not as exposed, or males who are perhaps binding their lower regions so erections are not obvious, especially in adolescence. Then we might have some of the medical treatment that goes into the hormone therapy, but not anything that is involving surgery. That third layer that we might see would be the surgery layer. We note that many people might feel uncomfortable being regarded by others or functioning as their assigned gender. Oh, wow, I thought I had another slide on that. I don't. Okay, a couple other things that you might keep in mind. There are specifiers if there is a disorder with a difference in sex development. And that is some very technically medical stuff that I'm not going to read to you. You can take a look at that in the DSM. You can also specify for adults if they are post-transition. So if they have transitioned to full-time living in the experienced gender, and that might be with or without surgery, might be with or without a legalization of a gender change, then you can use that post-transition specifier. As always with all of these diagnoses, there has to be some kind of an evidence of distress, which is going to be fairly obvious, I think, in this category. Prevalence is very challenging to find. It's probably highly underestimated, but the prevalence for gender dysphoria across populations is, they're guessing, to be less than 0.1%. Again, probably an underestimate. It is also important to take a look at some of the risk and prognostic factors. So we're going to be looking at the temperament, the environment, that includes the support or lack of support of family members, genetic and physiological issues or lack of issues might be important to explore. And also the issue of culture, so how culture might be related. So that is something to keep in mind. Definitely look at rates of suicidality or suicidal thoughts or behaviors in your individuals if they have a gender dysphoria diagnosis. It's a fairly high rate with a huge range. Our DSM talks about 30 to 80%. Again, huge range, but even 30% is enough to make sure you're doing those assessments. Some of those risk factors might include past maltreatment, gender victimization, depression, substance use, and that younger age. And you're also going to make sure you're doing some of that differential diagnosis. So a couple of other things that you might be ruling out include body dysmorphic disorder, autism spectrum disorder, and schizophrenia or other psychotic disorders. Comorbidity is also going to be an issue, and there's going to be a fairly high rate of comorbidity. Again, might be along with anxiety or some of the disruptive impulse control or depressive disorders. Also note that autism spectrum disorder is a little bit higher in individuals with a gender dysphoria diagnosis compared to the general population. So a couple of things to keep in mind when you are working with folks with gender dysphoria. I would also keep in mind that folks that have had this experience have likely had some very negative experiences within the healthcare field. So that might be with medical doctors, which they are often highly involved in, especially if they are looking for any hormone replacements, or if they're looking at potential of surgery, but also with mental health providers. So I know I've had multiple individuals that have been treated very poorly by previous therapists, and that is another thing that we are trying to work on overcoming in therapy, is not just the challenges that the individual has, but their challenges of their experiences within the healthcare and mental health care world. Okay, our second category for today is the disruption, impulse control, and conduct disorders. And this will include conditions involving problems in the self-control of emotions and behaviors. Typically in this, we're going to see it come out in behaviors that violate the rights of other people and or that bring the individual into significant conflict with the societal norms or authority figures. This does tend to be more common in males than females, and it tends to have a first onset in childhood or adolescence. So the first one that we're going to look at is the oppositional defiant disorder. You can see this starting on page 522. And that main feature is going to be the frequent and persistent pattern of angry or irritable moods, not moods, argumentative or defiant behaviors, or vindictiveness. And they may show this without having negative mood symptoms. So that might be important to know. We think that this might only happen if people have mood issues, but that's actually not true. What's interesting with this is, as opposed to some of the other things that we've looked at, this might be in only one setting. So we're going to look at a distinction between what's happening at home versus at school versus other settings. Most frequently, what we're going to see is that this kind of behavior is happening at home. So you might not see it in your clinical setting. So what we're seeing in other diagnoses is that the behavior is present in most settings. But if this is only happening at home, you may not see any of the symptoms when you're in the office with that individual. Again, symptoms are part of the problematic interaction with other people. And the individual that has this diagnosis is going to think that they're being reasonable. They think that they are justifying their responses as reasonable because the demand or circumstance is unreasonable. So they think it's unreasonable. And this might be something as simple as the parent will ask the child to put their dishes away. The child thinks that is an unreasonable demand. So their response is maybe to break the dishes instead of cleaning them. The individuals think that's reasonable. We would say that's not a reasonable response to the demand or the request to put your dishes in the kitchen. This is going to be more common in families where that childcare has been disrupted. So when we have a lot of inconsistency, multiple caregivers at that very young age, that is one of the situations that can cause some of this oppositional defiant disorder behaviors. Average prevalence of around 3.3%. This is something that we usually see a little bit earlier in age. So the first symptoms might begin in preschool. We're probably not going to see this later than early adolescence. So this is one that I would think of if I'm working with kids who are mostly elementary school, could be middle school. Beyond that, I'd probably look at some of the other categories that we're going to look at just now. The one that is kind of a little more standalone is the intermittent explosive disorder, starting on page 527. And this is where we see an impulsive or anger-based aggressive outbursts that have a rapid onset with little or no warning. So kind of out of nowhere and often in response to something very minor, people are going to become very aggressive or very angry. Typically, those outbursts are going to be less than 30 minutes. And they often have less severe episodes with verbal or non-destructive behaviors in between the larger episodes. So they might have some episodes where they're simply yelling at people, and then those bigger responses where they're maybe actually breaking something or causing some other form of destruction. Someone does have to be at least 6 years old. This is going to be a little bit more common later in childhood and adolescence. So I would start thinking about this with my teenagers. You're not going to see this as much after 40. There's often a history of physical or emotional trauma in the first 2 decades of life. That is the primary risk factor that you're going to consider. And that 1-year prevalence is about 2.6%, lifetime about 4%. And then we have conduct disorder. So one of the things that's kind of interesting is that there's a little bit of a progression through a couple of these diagnoses. So we looked at oppositional defiant disorder, and that's usually starting with those symptoms in preschool, so very young. So what might happen is someone starts with that oppositional defiant disorder. As they become older, they might develop a conduct disorder. Again, this is looking at primarily adolescence, even though it can be older. But from conduct disorder, if that is not treated, what we might see is a development into an antisocial personality disorder. There's a little bit of a flow in between those 3 diagnoses. So if you have maybe a 20-year-old that had a diagnosis in their history of that oppositional defiant disorder, and they're now above 18, which is when those personality disorders can be diagnosed, I would look at if that person now has antisocial personality disorder as a diagnosis. Same thing if you see someone with maybe conduct disorder in their history and they're now an adult, that's something I would explore. We do have multiple subtypes and specifiers. So a couple of things that you might use as specifiers could be childhood onset, adolescent onset. You could have a specifier of with limited prosocial emotions. You could have simply, oh, here's a couple others, lack of remorse or guilt, shallow or deficient affect. All of these are specifiers, in addition to that mild, moderate, and severe. So the couple of things that you're going to look at for your specifiers, see if you can find the best fit. In conduct disorder, what you're going to see the most is those repetitive and persistent patterns of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated. So typically we have those four main groupings that we're going to be exploring, and that includes causes or threatens physical harm to people or animals, causes property loss or damage, deceitfulness or theft, and serious violation of rules. So those are some categories that if you see some of those behaviors, like maybe you see some harm to animals, that might cue you in that this is the diagnoses that you might want to be exploring for that individual. They will often initiate aggressive behaviors or react aggressively to other people that can include bullying, threatening, intimidating, or causing physical harm. Typically, you're going to see the onset during middle childhood through middle adolescence. It's going to be pretty rare after about the age of 16. So that probably middle school and high school age is when I would start looking at this. If they're later in high school, maybe they're reaching around that age of 18, that's when I might start looking at personality disorders. So keep in mind that age range when you're looking at this as well. There is a 1-year prevalence around 2 to 10%, median around 4%. Again, this is really hard to judge exactly what it looks like. Again, a little bit higher in men versus women, so about 12% for a lifetime prevalence in men, about 7% in women. So those are the ones that we're going to look at for today. There is antisocial personality disorder in this category as well. However, the criteria and all of that is in the section for personality disorder, so we will take a look at that then. I will also note, even though we're not looking at the full range of these diagnoses, that pyromania, that deliberate and purposeful fire setting on more than one occasion, as well as kleptomania, recurrent failure to resist impulses to steal objects that are not needed for personal use or their monetary value, those are also in this category. So that is the end of our discussion for today. Thank you for joining us. We will be back next time with our next couple of categories of diagnoses.